Hello, good evening. Welcome to I Care for Your Brain with me, board certified neuropsychologist, Dr. Karen Sullivan. I am very excited for our topic tonight, brain health essentials for women over the age of 65. What is so special about this age of 65? Well, I hope that by the time I'm 65, I have amassed some significant wisdom. I hope I am the recipient of some important lessons learned. I hope I have learned to better stand up for myself. I hope I have learned to love and to be loved. This is also a time, though, in life where if you are lucky enough to transition into being 65, you also have a new label, and that is being an older adult. This is how science, including brain health, classifies us at different ages throughout the developmental lifespan. And so once we are 65, we are in a new category of being an older adult. And this is very important in brain science because it is the age that we have decided is when we should start having important conversations about brain health with folks. And this is because age is the number one factor for all of the subtypes of dementia. So in fact, the prevalence rates of dementia roughly double for every 5 years you are over the age of 65. So in these lectures, I do dozens and dozens of hours worth of research on a topic and distill it down to what I think are the most important and the most interesting essentials. So if you are a woman over the age of 65, please stay tuned. If that is you, you are definitely in the right place. Please stick around to the end because I'm actually going to be giving you access to some really important, helpful bonus materials. So when we start talking about women's health, what is the first thing that comes to your mind? The first thing most people think of is like OBGYN. But actually, we are focusing on brain health because there is good literature to suggest that the ability of the brain to remain as high functioning as it once was changes in women in unique ways as opposed to men. So how are we going to define brain health for our conversation tonight? We are going to say that brain health is the ability to remember, learn, plan, concentrate, maintain a clear and active mind that is satisfactory to a woman so she can live her values, what is most important to her. And like I said, the truth is that women's brains do age differently. And mostly this is because of our longevity and also the hormonal differences, specifically estrogen. So estrogen is not just a reproductive hormone. It's actually vital for energy metabolism, specifically in the brain. So we as women do live longer. That alone puts us at higher risk for developing diseases of aging, specifically Alzheimer's disease. So about 70% of the people diagnosed with Alzheimer's are women, okay? And the most rapid increase we actually see is in what we call the oldest old. So when you're 65 to 75, you are considered an older adult. When you get to the age of about 75, then you are considered the oldest adult. So 75 and up is the age group with the highest level of dementia for women. According to the Journal for Women's Health, the estimated lifetime risk for developing any form of dementia is 1 in 5 for women and 1 in 7 for men. And there's reasons for that we're going to talk about tonight. So because we live longer, we also tend to live alone in our older years more so than men if we are in a heterosexual relationship. So we need to be more aware of the signs, the symptoms, the type of evaluation, the treatments that we need for dementia because we might not have someone around who might notice. So for example, in the UK, 22% of women aged 65 to 74 are widowed compared to just 9% of men at the same age. And once we hit 75 or older, that percentage actually goes all the way up to 60% of women are widowed compared to only 29% of men. There's also the reality that women still play a disproportionate role in caregiving for our parents, for our husbands, for our siblings. 70% of all family caregivers are women compared to 30% of men. The average family caregiver is a woman age 46 to 56 who is employed and is not paid for her caregiving duties. If you were to add up all of the money that should be given to female caregivers in the world, every year it would come up to at least $550 billion. Okay. Dementia also affects women uniquely in social ways. And so what I read about is how some aging researchers are focusing on what they're calling a triple threat as a woman gets older who maybe has some cognitive impairment. So she's got the stigma associated with being older. She's got the stigma associated with being female, and then maybe the stigma associated with the decline in cognitive function. And so these sociologists think that this leads to these groups, this group of women being objectified and maybe doctors ignoring their complaints. So you've kind of got three different reasons why your concerns about cognitive decline might not be taken as serious. So when I hear this, what I want to do is empower you, the audience, with the information that you might not get otherwise. So the first thing we have to do is figure out what the problems are. So women in brain health, the first problem is not enough women know the signs and symptoms of dementia. We're going to change that tonight. The second one is not enough women understand the limitations of what your typical primary care doctor or even your neurologist may do as what we call a cognitive screen. So we're going to change that tonight. Not enough women are confident in understanding what different signs or early symptoms of dementia may be. And not enough women fully understand what treatment options are out there for dementia. So no more, we end this tonight, okay? The first thing we're gonna talk about are what are the signs of normal aging versus dementia. So what is normal once you are a woman who's over the age of 65? What is normal is you are going to notice a decline in your hearing and vision. That's a given for almost all of us. And that is going to potentially make things harder to hear and to focus on. So that's key. You got to get those things optimized. You're also going to notice a mild decline in your ability to rapidly recall information, specifically people's names. So if that is happening to you, do not overly worry. Do not get overly anxious. You may also notice a decline in your multitasking speed, not your accuracy, but the quickness in which you can do multiple things at one time. In normal cognitive aging, women are independent with their instrumental activities of daily living. So what are those? Those are managing your finances, remembering to take your medicines, and driving. The most sensitive of those three things is money. If you are balancing your checkbook, if you're remembering passwords to your online account, if you have an Excel spreadsheet with your investments or where your money is, chances are you're doing just fine. When cognitive issues present themselves to the degree that we worry about dementia, they interfere with those instrumental activities of daily living. So think of dementia as kind of an umbrella term, okay? It's a very broad category, and there's many diseases under the umbrella that cause dementia. So you can have dementia but not have Alzheimer's disease. But if you have Alzheimer's disease, you have dementia. I hope that makes sense. So the common dementias are Alzheimer's, vascular dementia, Lewy body dementia, Parkinson's disease dementia. But we also have reversible treatable conditions that mimic dementia. So some women can be so depressed for a variety of reasons that they start actually looking and sounding and feeling like they have dementia. We call that pseudo-dementia. We can see changes that look like dementia in thyroid disorders, urinary tract infections, medication effects. So it's very important, and we're going to talk tonight about what is that gold standard cognitive eval that you deserve. Dementia is a syndrome that has three parts. So it's not just a memory problem. There are cognitive symptoms, which can be in any domain. They can be attention, word finding, visuospatial, learning, multitasking. The second part is function, and we already touched on that. How are you in everyday life? Are you able to be independent and fulfill all of the needs that you have for transporting yourself, going to the doctor, making sure you're paying the bills? And the third one is mood and behavior, and this is something that often gets overlooked by people. We so commonly associate dementia with only a cognitive change, but there's always some changes in mood and behavior as well. So what are these? These are typically decreased interest in things that you used to like, okay? More irritability. That's kind of on the one end of the spectrum. And on the other hand, we have all the way to delusions, paranoia, visual hallucinations. The key in dementia is when something changes. If you have always been a little flighty, if you've never had a great memory for names and it maybe gets a little bit worse as you get older, that's not really concerning. The big concern is a discrepancy between the way you've always been and now the way you are, and the impact on function. If you need someone to help you remember how to get to familiar places, if you pay the wrong bill, if you can't seem to keep straight your medication regimen, these are concerns. These would be reasons to want to advocate for an evaluation. So what do those typical evaluations look like? Well, there's going to be 3 types of medical providers that will be involved in your cognitive assessment journey if you feel like you need one. The first one is your primary care doctor. That's a great place to start. Typically, then people get sent to neurology. So these are physicians who have expertise in the brain. And then the lowly one on the bottom is us, neuropsychologists. And very often, once a medical community works with a neuropsychologist and sees the value that they bring to patient care in terms of comprehensiveness, building a relationship, and the really strong diagnostic accuracy and the personalized recommendations, we tend to get brought in the loop a lot earlier. But there are only about it's probably between 1,000 and 1,500 board certified neuropsychologists in the United States. So there's not a lot of us. If you go, like most of you will, to primary care or neurology, about the extent of the assessment you're going to get for any cognitive concerns is you're going to be given what we call a cognitive screener. So what this is a 3 to 5 minute test asking you what year it is, asking you to remember 3 words, asking you to count backwards from a certain number by 4, these kind of things, right? These screening measures have their place, but what I need you to know is they're not the end of the conversation. If someone does this type of test to you and you don't feel like it hit the mark, you feel like you struggled more than you should, then you need to advocate for a proper evaluation of the brain, which is a neuropsychological evaluation, okay? There are many instances in which these screening measures are not adequate as standalone, meaning this cannot be the end of the assessment. So what they are there for is an attempt to reduce subjectivity, meaning here comes a patient and they say, I can't remember what I came into a room for, or I keep losing my keys. We're trying to take those patient complaints and turn them into data with a standardized approach. And that's good, right? We like that. It's a science-based method. And what we're trying to do is determine what is normal age-related function versus maybe a type of dementia. The problem is we consider them to be quick and dirty, right? They do have their place, but they're very decontextualized. So what I mean by this is they don't take into account anything unique about the individual. So they're not sensitive to if you have very low education or very high education. So what I mean by that is maybe someone starts off in the superior range of intelligence, right? Maybe high average, and then they perform in the average range. Well, if you don't understand the education, the danger is that you are going to interpret that average as normal when it is in fact a decline for that person. Average is not necessarily normal for that person. The other concern is, what if you came into this cognitive screen with severe dyslexia? What if you could never spell the word winter backward? But now you're getting dinged, a point is being taken off because you can't do that. So there's no context, right? These tests have been criticized because they aren't sensitive to vision issues, hearing issues, different types of cognitive impairment. There's typically no alternative version. So what I know from my patients is they typically know exactly what they're going to be asked. They know they're going to be asked the year. I've had patients come to see me and I open up their hand and I see ink and it says 2022, Biden, Trump. They know exactly what it is that I'm going to ask them. So what I want you to know is screening measures are the first step in a proper evaluation. So it's a good start to a conversation, but it cannot be the final piece of information that we use to make incredibly important determinations, like if you're aging normally, or if you have dementia, or what subtype you have, or what we're going to do about it. So what I want you to do is advocate to be referred to a neuropsychologist. So even if you get a perfect score, right? Most of them use a scale of 30. If you get a 30 out of 30, but for you, you're worried, then ask for the referral. If you have a family history of anyone with dementia, the younger someone is when they develop dementia, the more genetic it is. So the more you are at risk for that type of family history. Ask for a referral, right? Maybe you just want a baseline. You just want this type of referral because you want to know what are your personal risk factors for developing future dementia. Maybe there's not even anything happening now. This is something that Medicare covers. This is something that you have a right to. So what do we do as neuropsychologists? We do all sorts of awesome things. I often think of us as kind of the best friend in brain health care that you never knew about. We spend a lot of time. We are very sensitive in our approach. We look at a lot of medical records. We make sure we know all your medications, all your supplements, so that way we are understanding if there's any impact there. We do very in-depth interviewing. I just did an interview before I came on here. That was an hour and a half. There was just so much history that we needed to go through so I can make the best discovery of understanding what is happening to this person. And then what we're really known for is paper and pencil testing. So we can determine how would someone of your age and your education and your background have performed on a series of tests. Then we look at the overall pattern and we are able to say, this is the pattern of normal aging for this person. Oh boy, this is the pattern of early Alzheimer's. This looks like vascular dementia. Have you maybe been worked up for Parkinson's? Maybe you're so depressed that I can tell your memory is actually good, but you're so tired and exhausted and your energy is so low because you have depression or a sleep disorder that you're actually looking like you have dementia. Okay, so the evaluation is key. Now, what's going to happen if you do get diagnosed with dementia? We have to talk about these things. So we have no cure, we have no disease-modifying treatment, but what we do have are treatments that can alleviate the cognitive, the behavioral, the psychological symptoms, okay? So treatment for dementia depends on the subtype you have. You just don't go willy-nilly throwing dementia medications at any older adult who can't remember. You have to know what it is you're treating. So the main medication approaches in middle to high income countries are what we call cholinesterase inhibitors, okay? So what they do is they basically block the normal breakdown of a chemical messenger, a neurotransmitter called acetylcholine that we need for learning and memory. The three main types of these medications that we typically think of for Alzheimer's, but they also help other subtypes, are donepezil, galantamine, and rivastigmine. We also have Namenda, which works a little bit different on a different chemical named glutamate. But your neuropsychologist can help match you not only with the best one medication, but sometimes we like a combo. And we also like to have input on the milligrams. Now, we're typically not prescribers. We're not physicians. We are neuropsychologists. So what we do is we make these recommendations back to a physician or a PA or a nurse practitioner who then reviews. If they agree, then the prescription happens, okay? No medication on the market is a cure. None of them reverse cognitive impairment. They don't prevent. What we do really strongly believe is that the earlier someone gets these medications, the better. So that's part of why we want to talk about what to look out for, because we don't want people waiting until things are so severe that they wouldn't have the full benefit of these medications. Now, in developing countries, treatment tends to not be medication related because there's just a lack of access. So now that you understand dementia better, this is actually the heart of the lecture, if you're still with me. This is the deeper dive. This is actually fascinating. I had put out a message earlier that I hope people join me tonight because I actually think this is maybe the best lecture that I've done in 5 years. I know that's saying a lot because there's really been some good ones because you all feed me really good questions, but I have to say I learned a lot. I think if you are a woman, if you are over 65, you really need to understand this information. So let's start off by saying that women's brain health is very understudied. I bet you are not surprised by that at all. But boy, do we know a lot about the prostate, right? The intersection of gender and dementia is very, very complex, and there's a lot of contradiction. So what I have done is gone through this body of literature for you, and I have pulled out what I consider to be firm, reliable conclusions, okay? So there is not one risk factor that we can point to and say, this is the big thing that you have to worry if you're a woman over 65. What I can tell you is there is a lot of complexity, and there's a lot of what we call modifiable and non-modifiable risk factor that basically make genetic predispositions to dementia kind of bloom, blossom, kind of bring them to life, okay? There's multiple unique things that only are relevant to us as women. The big ones are sex-specific genes, so genes that we only see on the XX chromosome, reproductive hormones that mostly come down to estrogen, and depression. These are the three things that seem to uniquely change the future of brain health for women. So let's go through these, okay? So if you have an XX chromosome pattern, you are going to just live longer, okay? The reason, this is so interesting, the reason that we live longer is because of how good our immune system is. Our immune system is better as women than men's are. And part of it is we think that we kind of have a smarter, more fine-tuned immune system because of childbirth, that we can be able to have such a non kind of natural foreign object in our body, and the immune system doesn't reject it. So the immune system for women, it seems, just has a level of sophistication. Now, it does not come with its downsides, because there's some really interesting research that our propensity to have autoimmune disorders is a factor. But let me just take one step back. So as women with the XX chromosome, we also are much more likely to be carriers of one of the strongest genetic markers for Alzheimer's, which is called ApoE4, okay? And so 15 to 25% of the general population carries this gene. But what we know is that when women reach the age of about 60, 65, and they have one of these genes, they have a 4-fold increased risk of developing Alzheimer's disease, even compared to men who have the same genetic mutation. So that's pretty significant. And what they think maybe is that by the time you're 60, 65, our estrogen levels are just going way down, and there's some interaction effect between ApoE and estrogen. We're going to talk about that a little bit more. So having this ApoE4 genetic mutation basically means that your brain is going to produce more of one of the two pathological markers of Alzheimer's. So we have amyloid plaques and we have tau tangles. So ApoE4 is associated with increased tau. So what that means is if you have it, your brain is going to be more likely to get these kind of scrambles that suffocate brain cells. So the idea is that having less estrogen also creates tau production or increases tau production. So then we've kind of got these two impacts interacting with each other to result in more Alzheimer's disease. So again, like I said, what's really interesting is women have a superior immune system. Can't help it. It's just what the science says. And that means our inflammatory response. The immune system basically works through inflammation, right? The problem is when inflammation doesn't come and go and it's chronic or low grade, or when the immune system goes so haywire that it actually turns on ourselves. And that's what autoimmune disorders are. So there's some research out there to say that having one autoimmune disorder basically accelerates brain aging. And I do want to do a separate lecture on that topic in the future. I have 2 autoimmune disorders myself. And so when I saw that, I was like, oh boy, we need to research that. So for every 1 man that gets multiple sclerosis, 3 women get it. For every 1 man, 7 women get rheumatoid arthritis. And for every 1 man, 16 women have Sjögren's, right? Which is an autoimmune condition that makes your eyes and your mouth dry. Thyroid issues, Hashimoto's thyroiditis is something that's much more common in women, and probably it's related to uncontrolled inflammation, okay? So this also becomes relevant with estrogen again. So when you start to look at the literature on estrogen and dementia, what you really see is it all starts at perimenopause in your 40s and your 50s. So once your ovaries start pumping out less sex hormones, specifically estrogen. You also see, so less estrogen, more chronic low-grade inflammation, unfortunately. What they don't really know is how much of it is pure estrogen, or is it the problems that low estrogen causes. So women tend to gain weight. They tend to have sleep disorders because of hot flashes. They tend to have some anxiety because of the quick drop in estrogen. So what I couldn't figure out from the literature is what's the chicken or what's the egg. But basically those two things happen together. And about 80% of people going through 80% of women going through perimenopause do have some type of cognitive complaint. Okay, so that is unique to us. We also know that a part of what estrogen does is it's not just a sex hormone, it also is related to glucose metabolism. And when you have less glucose, less sugar being taken up by brain cells, we do see a reduction in brain matter, gray and white matter. And we tend to get that increase in amyloid, which is one of those pathological features of Alzheimer's disease. So estrogen is really a master regulator of our metabolism, and this is part of why the weight gain happens. But we can also get what they're calling an energy deficit of the brain related to lack of estrogen. So this really makes diet, making sure you change your diet to be more supportive of your brain and your body in perimenopause and postmenopause is super important. And that's what we're going to talk about at the end. So they also looked at women who have undergone HRT, hormone replacement therapy. And that's a whole world that really does require its own special time. But what I'll tell you is they have done 2 meta-analyses, basically putting together tons and tons of research. And what they found was estrogen replacement therapy in most studies wasn't always consistent, but basically reduced the chance of getting dementia by about 30%. But what something called the Women's Health Initiative study came back and said is that the benefit wasn't seen for all women. What they saw was the younger that you were when you started hormone replacement therapy, the less likely you were to get dementia. Then a whole nother study came out and said, no, actually, we're sorry. We didn't see that finding. So it's honestly kind of up in the air, but these are the kind of informed conversations that I want you to be having with your provider. When you think about hormone replacement therapy, I want you to ask them, what do you know about the relationship of estrogen and dementia? Okay, that's why we're here, is to empower you and to help you be more informed so you can have more equal conversations with your medical providers. So there are some risk factors in women that are particularly influential in developing dementia. Hypertension, high blood pressure, has been proven to be greater in men than in women up till the age of 60. And then after, women actually take over men. So in about 75% of women over the age of 80 were found to be hypertensive, too high. This then impacts brain health by blood vessels becoming too small, not enough oxygen can get through, not enough glucose can get through, and what we start to see is brain cells dying and we see shrinkage. So that's what we don't want. We also know that women who have diabetes for more than 15 years are shown to be at about 57 to 114% greater risk for cognitive decline than women without diabetes. So those two things, ladies, blood pressure and diabetes, be obsessive about making sure those things are well managed. The next one is mood. So for some reason, subclinical, mild threshold depression is associated with increased dementia in women only. One of the factors I read about, again, was inflammation. The other question is, well, does being depressed make you less likely to exercise, make you turn towards sugar and simple carbs for comfort? Is it the way depression can upset your sleep? They are not sure, but watch your mood. That's what we need to drive home there. So now I want to talk about not just the risk factors, not just kind of the don'ts, but I always, we take a very positive approach to aging here at I Care for the Brain. What are the things you can do as a woman over 65 to reduce your risk of developing dementia? So I have gone through all of this literature, hours and hours and hours, to serve you up on a silver platter the 5 evidence-based recommendations that I want you to know about the most. The number one, I bet you can guess, is exercise, increased physical activity. 25% of Americans are sedentary and more than 60% do not exercise regularly. Exercise equals more blood flow to the brain. Blood carries the fuel that brain cells need: oxygen, glucose, micronutrients, okay? The association between physical activity and increased protection to Alzheimer's disease are exceptionally huge in women. Even more so, the association between the benefits of physical activity and brain protection are even more in women, okay? Stronger in women than they are in men. So we think that there's a reduction in risk for Alzheimer's of about 60% of women who do high-level physical activity compared to no physical activity at all. So I always like to define what we mean by these terms. So this is about every day getting 20 to 30 minutes of movement, 3 times a week doing some kind of strength training. And what the neuroscience research tells us is that dual task training is top. So what do I mean by that? That is doing this, hitting your head on top and walking and chewing gum, doing 2 things at one time. So as you're exercising, do your multiplication tables in your head. Think about the state capitals of as many states as you can think of. Try to be doing an intense physical activity and also some kind of cognitive engagement. That is very strongly associated with people who have the best aging brains. The second recommendation is you have to eat for brain fuel, okay? So what we're looking for in a brain healthy diet is high in quality fats, good clean protein, and micronutrients that only come from fruits and vegetables. There is only one diet that has research that supports a reduction in Alzheimer's disease or cognitive impairment after stroke, and that is called the MIND diet, Mediterranean Intervention for Neurodegenerative Delay. And it just so happens that we have a wonderful handout for you to download that we're going to put in the comments that is all about the MIND diet, teaching you all about it, how to adhere to it. The other thing I would really love for you to learn more about is gut health. This was the topic of my latest webinar. We did this a couple months ago. We sold out. People just loved the topic. And we're going to put the link to that in the comments. When folks signed up for the Gut Health, Brain Health webinar, they were given free bonus materials that went along with their registration. And so what I would love to offer all of you listening to me today is these bonus materials for free. So Carrie is going to put them in the comments when I am done with the lecture here. So please look into it. If you're interested in the brain health, gut health seminar, it was really, really, really good. I have to say, we learned so much. There's so much specific instruction, things you never even thought were important for brain health are related to gut health and the connection with the vagus nerve. The third recommendation is to reduce your inflammation. Be mindful about inflammation. Ask your primary care doctor for a lab called the C-reactive protein. This will tell you the general amount of inflammation that you have in your whole body. Okay, there's also one called C-reactive protein high sensitivity that will tell you just related to your heart and inflammation there. The most helpful thing you can do for inflammation is exercise and to not eat too many calories, not eat highly processed food, and make sure you have some muscle mass. Having muscle mass reduces inflammation. We now know so much more about diet and brain health that luckily science and scientists are packaging together. It's not a supplement-driven intervention anymore. It's whole foods oriented, and we have to be giving people the very best advice that we can on what to eat for brain health. The next one is to manage chronic stress. Women are twice as likely to have severe chronic stress and anxiety. This was shown in a journal article for Brain and Behavior. It is not realistic to think you are going to avoid stress completely completely, but what I can tell you is that you can learn to manage it better. When you are always stressed, your cortisol is elevated, and cortisol is an inflammatory creator. That's exactly what it does because it thinks you're under threat all the time. So it wants your immune system to be absolutely on guard. This is probably related to some of the autoimmune issues that we talked before. One of the things that is so key is to have a flexible nervous system. So what I mean by this is not always being hyped up, hypervigilant, and not always being kind of low energy, low interest, right? You have to be able to modulate your basic energy level. And many of us are very good about having it high. We don't know how to come down. So this is where mindfulness, being in nature, listening to music, listening to guided meditations, all of these things are super, super important for brain health. The next one is to balance high quality sleep with high engagement during the day. Sleep is essential for brain health. When we are in a deep sleep, the brain is basically creating memories, processing emotional trauma, and cleaning itself, breaking down the things that we don't need anymore and flushing them out of the brain. Sleep does change with age, period. We take longer to fall asleep. We're more sleepy as women once we're over the age of 65. 40% of us will report some insomnia once we get to 65, and we're twice as likely to have restless leg syndrome. So if you don't feel like you wake up refreshed, if you feel like you can fall asleep anytime, if it takes you more than an hour to fall asleep, if you wake up in the middle of the night and can't fall back asleep, talk to your primary care or your GP about sleep and maybe consider a sleep study. That's the gold standard to see if you're going through all 5 stages of sleep and if you're specifically getting enough REM sleep. Wow, I told you this one was going to be good. So please tell me what you think. If you found value in this, let me know in the comments. Subscribe to our YouTube page. Follow us on Facebook. This is something that we've been doing for 5 years. So if you're just finding us, go to the archives and look for any topic you can think of in brain health. At this point, I think I've covered almost the vast majority. Next week, we're doing a audience choice where we had people vote on our Facebook page for what next week's topic would be, and people picked statins. We're going to talk about statins and brain health. So please join me next time. I'm so glad that you were able to spend this time with me. I hope that you are more empowered and feel like you are more able to advocate for your own brain health. Thank you so much and take care until next time. Bye-bye.